What you are seeing here is the physical collapse of hematopoiesis, dense, active marrow islands dissolving and being replaced by sterile, yellow adipose tissue. But this barren microenvironment is a phenotype. It is a clinico-pathologic state, not a final diagnosis. This chart maps out dangerous clinical shortcuts in hematology, beginning with the common assumption that a patient presenting with Pancytopenia and an empty marrow is a confirmed case of acquired aplastic anemia. Another shortcut occurs when the presence of dysplasia and a somatic mutation is used to finalize a diagnosis of myelodysplastic syndrome, or MDS. The third is the reflex to push for an immediate stem cell transplant the moment the cytogenetic abnormality Monosomy 7 is discovered. And the final trap is the belief that a sibling with a normal CBC is inherently a safe transplant donor. Every single one of these reflexes can be fatal.
Acquired immune-mediated destruction, inherited stem cell disorders, and clonal myeloid diseases look identical under the microscope. This brings us to the cardinal rule of bone marrow failure. You must never begin immunosuppression or standard conditioning regimens until an inherited germline syndrome has been reasonably excluded. Relying on morphological phenotype alone leads to misdiagnosis. Uncovering the true underlying biology requires a strict algorithmic integration of functional testing, cytogenetics, and molecular data. Before launching an investigation into marrow failure, the first step is to validate the cytopenia itself. You have to exclude artifactual laboratory errors, like EDTA-dependent platelet clumping or cold agglutination affecting the CBC indices. Once confirmed, the dominant lineage directs the diagnostic logic. Isolated anemia points to an erythroid defect, isolated neutropenia to a granulocyte disorder, and pancytopenia forces a broad evaluation of global failure, infiltration, or peripheral destruction. This decision tree illustrates how we separate production failures from peripheral destruction. The premier functional marrow test to force this split is the absolute reticulocyte count. A high absolute count indicates the marrow is actively functioning and attempting to compensate for hemolysis or blood loss. Conversely, a low or inappropriately normal reticulocyte count in the face of anemia dictates a marrow production problem until proven otherwise. If a patient presents with an isolated macrocytic anemia and severe reticulocytopenia, the algorithm forces a critical fork. You are looking at either an acquired or an inherited pure red cell aplasia. Acquired pure red cell aplasia is typically driven by autoimmunity or an infection like parvovirus B19. Its inherited counterpart, diamond black fan anemia, is a congenital ribosomopathy. It usually presents in infancy and is marked by elevated erythrocyte ADA and fetal hemoglobin. Bypassing a simple physiological marker like the absolute reticulocyte count blinds you to this exact distinction, leaving you unable to tell an immune attack from an intrinsic congenital defect. When facing a pancytopenic patient with an empty marrow, a trophine biopsy is strictly required. You cannot accurately assess true cellularity for a patient's age from an aspirate alone. Acquired aplastic anemia is a diagnosis of exclusion. It requires a bland, profoundly hypocellular marrow with absolutely no access blasts. Detecting a small PNH clone strongly supports the diagnosis of an immune-mediated acquired aplastic anemia, though its absence does not completely rule it out. This three-way pathway diagram compares acquired aplastic anemia with its major morphological mimics. Notice the specific morphologic red flags that strictly rule out simple AA, the presence of convincing dysmegakaryopoiesis, specifically micromegakaryocytes, and CD34-positive blast clusters. Finding these dysplastic features mandates a shift to a hypocellular MDS diagnosis, pivoting the clinical focus toward malignancy-directed therapy and high-risk surveillance. The third category, inherited marrow failure syndromes, perfectly mimics both AA and MDS morphologically. Identifying them require targeted functional tests, VEB or mitomycin C breakage for Fanconi anemia, and flow-fish telomere length testing for telomere biology disorders.
Extra hematologic features often clarify the diagnosis. Pancreatic insufficiency coupled with neutropenia suggests Shwachman-Diamond syndrome, while warts, lymphedema, and monocytopenia signal GATA2 deficiency. Do not rely on physical appearance. Fanconi anemia and telomere disorders frequently present without any obvious congenital anomalies. You also have to discard the myth that these are exclusively childhood diseases. Germline diseases like DDX41 mutations or adult telomere disorders commonly present for the very first time in older adults. Assuming a hypocellular marrow in a structurally normal adult is acquired aplastic anemia is a catastrophic error. The visible morphological damage hides vastly different underlying molecular mechanics. Within cytogenetics, Monosomy 7 is a high-stakes abnormality that demands immediate, highly specific clinical routing. This decision tree, originating from Monosomy 7, outlines the phenotype assessment. In children, Monosomy 7 is not an automatic mandate for a transplant. It can represent a somatic rescue event, compensating for specific germline diseases. The GATA2 branch of this algorithm is triggered if the Monosomy 7 is accompanied by Monocytopenia, B and NK cell loss, or atypical mycobacterial infections. Alternatively, the SAMD9 and SAMD9L branch is triggered by severe growth restriction, adrenal insufficiency, or ataxia. When we shift to myeloid next-generation sequencing, we face another trap. Detecting a somatic mutation does not automatically confirm an MDS diagnosis. You have to interpret the specific variant. Mutations in PIGA or B core form small, stable clones compatible with immune-mediated aplastic anemia. Conversely, mutations in RUNX1 or an expanding TP53 clone act as high-risk drivers for malignant progression. If sequencing reveals a predisposition variant at a variant allele frequency near 50%, germline confirmation is strictly required.
However, for that confirmation, the gold standard tissue is cultured skin fibroblasts. Peripheral blood or saliva are highly unreliable for germline testing in these patients. Because of somatic mosaicism or prior transplants, the DNA in the blood may not match the patient's actual constitutional genetics. Applying advanced molecular sequencing to the wrong tissue type yields false negatives. It blinds the hematologist to the patient's true genetic baseline. When a diagnosis of acquired severe aplastic anemia is definitively confirmed, the therapeutic logic is straightforward: immunosuppressive therapy or a matched sibling stem cell transplant, depending on the patient's age and disease severity. However, immunosuppressive therapy is useless and actively dangerous for inherited marrow failures like Fanconi anemia or telomere biology disorders. Misapplying IST to a germline disorder achieves nothing but delay. It postpones curative transplants and exposes the patient to lethal infection risks without any biological chance of marrow recovery. Even when moving to transplant, the conditioning regimen must be tailored to the underlying germline biology, not just the blood counts. Subjecting a Fanconi anemia patient to standard genotoxic intensity conditioning will catastrophically damage their tissues because their cells lack the intrinsic machinery to repair DNA double-strand breaks. This brings us to the final and perhaps most dangerous clinical shortcut in bone marrow failure: the selection of a related donor for transplant. This pedigree chart highlights the sibling trap. An asymptomatic sibling with a perfectly normal CBC cannot be assumed a genetically safe donor. Harvesting stem cells from an untested sibling results in poor graft function, the transmission of marrow failure, or donor-derived leukemia. Targeted testing for the familial pathogenic variant is strictly required before any related donor can be mathematically cleared for use. Treating marrow failure requires identifying the biology that caused the failure, rather than reacting to the sign of Pancytopenia or the phenotype of an empty marrow. Success is found in mapping the mechanism, not just the morphology.